to 15 months, whereas with conventional radiotherapy, there is no flare. Essentially, the urinary toxicity just deteriorates, or improves rather, over time. This flare, however, is not universally seen. This is a trial that's a bit similar to your Patriot study. This is the one by Thomas Zilli, where they treated men with SBRT either weekly or every other day. And they used this kind of strategy here that's demonstrated in the schematic, where they did a dose donut, if you like. So it dips the dose around the urethra, and to quite low levels. They covered the whole urethra with 30.9 gray and kept the D2% of that area below 34.7. So quite a significant dose dip compared to what we normally deliver. But with this strategy, they didn't see a flare in toxicity out to 18 months in either arm. And so that does lend some support to the theory that this is about urethral dose. And of course, you guys have got a lot of experience of brachytherapy, and that brachytherapy itself contributes to that evidence suggesting that urethral dose is important. Now, coming from a different angle, what about the dose we give? So why do we give the doses that we do in PACE? So initially, so the Deborah Freeman and Chris King paper, those doses were essentially calculated using a linear quadratic model from our standard fractionations. But at the MSK, Mike Zalewski and the team did a cohort study of sequential dose cohorts escalating from 32.5 gray up to 40 gray without ADT, fairly small prostates, and at least 3 years of follow-up in all groups. First thing they found was that there doesn't appear to be a big correlation between dose and the toxicity, either acute or late. There is a slight trend to more toxicity with more dose, but that was not statistically significant. But the more interesting thing in this study is that they did a follow-up biopsy at 2 years after SBRT to look and see who's still got active cancer, or at least potentially viable cancer in their prostate. Now, having stuff that looks like prostate cancer in your prostate is not a guarantee you will have biochemical failure, but it's certainly a good marker of it. And they found that if you only had 32.5 gray in 5 fractions to your prostate, then nearly half of the men actually had cancer still visible on their biopsies. Whereas if you went up to 40 gray to the prostate, only 7.7% had viable cancer visible on their prostate biopsy. So that's quite interesting. And that I think is why we've ended up with this dose of 40 gray to the prostate CTV. And this is how we do it in PACE. So this is the dose schematic. So the darker blue here is the prostate. And in PACE, we give that 40 gray to the prostate itself with no margin. And the PTV goes to 36.25 gray, and the margins in PACE are between kind of 3 and 6 millimeters for SBRT. There was a small range to accommodate different practices. I think you guys use 4 millimeters, we use 5 and 3 posteriorly, but all much the same. And for PACE B and subsequently PACE C, which I'll come on to, we try and include the proximal part of the seminal vesicles in the prostate volume. So that should get the whole PTV dose of 36.25 gray. And the way we've helped people construct that for PACE C, because this caused a lot of confusion, I think, in PACE B, is that we ask people just to contour the prostate and then to expand that volume by 1 centimeter. And any of the SVs that arises in that expanded volume counts as part of the proximal 1 centimeter of SVs. So that's how we try and standardize the volumes that we draw for the trial. And for PACE C, of course, we're including a little bit more SV. These are higher risk patients than we've treated before. And so we have a second volume, which goes up to 30 gray and includes the proximal 2 centimeters of seminal vesicles, just to allow a sort of microscopic dose to the more distal SVs, which may have a little bit of cancer there occasionally. When we plan SBRT within the PACE trial, we have some mandatory constraints. These are very similar, I think, to the ones you use in Sunnybrook, and are quite similar to many other trials around the world. They're all derived essentially from the early US experience. And we consider these mandatory. So in other words, I will undercover the target to meet these constraints. And with that, we achieve low levels of toxicity. Now, coming back to the alpha beta ratio, these are the two doses that were used in PACE-B, which I'm going to show you some data from next. So you can see across a range of alpha beta ratios from 1.5 over on the right-hand side to 3 here on the left, that 62 in 20, which were the doses used in PACE-B, and 36.25 in 5, achieve very similar doses, biologically equivalent across that range. However, I've just told you that the prostate CTV itself goes up to 40 gray, and regardless of the alpha beta ratio, that's actually a relative dose escalation compared to our standard doses. So we need to bear that in mind when we look at both the toxicity and eventually the efficacy of in PACE-B. And just to put that in context of other evidence, so the dose I've added on the bottom of the table there, 42.7 gray in 7 fractions, is a dose from the HYPO trial, which I'm going to mention next. And you can see that this achieves very similar doses to the standard arms of 2 standard arms of PACE-B. And this is the HYPO trial. So this was a Scandinavian study led by Anders Widmark, which randomized men to either 78 and 39, which was their standard fractionation, or this slightly unusual dose to us of 42.7 gray in 7 fractions. And most of you listening will know already that this is published and shown to be equivalent in terms of biochemical outcomes. And there are only minor differences, if any, in toxicity between those 2 fractionations. So that gives us quite a lot of reassurance that PACE-B and hopefully PACE-C are likely to be achieve a similar efficacy, which is reassuring at this stage. So this is the PACE umbrella as it's become. It's started off as PACE-A and PACE-B, and we've added PACE-C, and it's about to sprout a new arm called PACE nodes, which I'll tell you about in a moment. So the original idea was to compare 5-fraction SBRT with standard treatments, which could either be 4 weeks of radiotherapy in PACE-B or surgery in PACE-A. And PACE-A has been quite a challenge. It's still open, still recruiting. I think we've got about 125 patients in, but it's been recruiting for years and years. And we've had trouble engaging urologists and less trouble engaging patients, actually, but it certainly takes a bit more discussion to ask a patient to randomize between surgery and SBRT. That has proven difficult. PACE-B, on the other hand, has been a dream, and thanks to your collaboration in Canada for that. In PACE-B, we recruited 874 men and randomized them between 4 weeks of radiotherapy and 5 days of radiotherapy. And I'll come on to some more details about that now. So the patients we recruited for this trial were all T1 or T2, Gleason 3+4 or less, and PSA less than 20. Everyone was MRI staged and nobody received ADT. So this was a favorable intermediate risk group, and we didn't feel they needed to have ADT. And they were randomized 1-to-1 between conventional radiotherapy, which was this slightly unusual dose of 62 and 20, or 78 gray and 39 fractions over 4 or 8 weeks, versus SBRT, as I've just described. And it was permitted to treat over 1 or 2 weeks, so either daily or alternate daily. And the primary endpoint of PACE, of course, is biochemical or clinical failure, and we won't have that data until 2023, but we have already published some of the toxicity data. In terms of the patient cohort, it was almost exclusively an intermediate risk group. You, like us, don't treat much low-risk prostate cancer any longer, so most of the men going in had intermediate risk disease. Over 80% had Gleason 3+4, and about a third had a PSA of 10 to 20. As I've shown you, we treated the prostate and the proximal centimetre of seminal vesicles, and we gave daily IGRT to the prostate, which could be either fiducials or cone beam image guidance daily, matched to the prostate. For the conventional radiotherapy arm on the left-hand side in yellow, just over a half had fiducials as their image guidance strategy, and the majority had 62 gray in 20. For the SBRT arm on the right-hand side, 3/4 had fiducials, and about 41% had treatment delivered on a CyberKnife. The rest were delivered on a conventional Linac. We published a couple of years ago now the acute toxicity data, and essentially the message from this is on the RTOG scale for both GI toxicity, there's no difference. So in other words, the chance of you getting a grade 2 acute GI toxicity during radiotherapy is now about 10%. In terms of GU toxicity, the rates are higher, so about a quarter of men get grade 2 RTOG toxicity in the acute toxicity period, but that tends to settle quite quickly, and only a bit of grade 1 toxicity is left by the end of the acute toxicity period. At ESTRO last year, we presented the 2-year toxicity data from PACE-B, and we wrote a statistical analysis plan prior to the analysis, and we pre-specified 2 co-primary endpoints and split the p-value, so they were considered significant with a p-value of less than 0.025. There are lots of secondary endpoints, and for that reason, we've reduced the significance level down to 0.01, and I'll show you some of those endpoints today as well. So firstly, in terms of GI toxicity, the rates were incredibly low. Only 1.6% of men had grade 2 RTOG toxicity at 24 months after radiotherapy in the SBRT group. And there was no statistical difference between those two at any point during the follow-up period so far. However, it's all very well knowing what the doctor said. What does the patient actually say? And this is data that will come out in the paper shortly, I hope. So if you ask patients their experience of their toxicity, there is a detriment in their quality of life that you can pick up on the EPIC scale. And this graph represents the proportion of patients who have a change in their quality of life that meets the threshold of minimally clinically important difference. And this is predefined by the EPIC questionnaire. As 5 points actually for bowel side effects. So you can see here that there's a majority of patients get worse compared to the number that get better, just randomly. And that does appear to be a little bit worse for the conventional radiotherapy on the left-hand side compared to the right. Then moving on to GU toxicity. So there were some differences visible in GU toxicity throughout the toxicity period from 6 months to 6 months to 24 months. And these were significant for the CTCAE scale, where the rates of grade 2 GU toxicity at 24 months were 5.8% if you had conventional fractionation and 11.8% for SBRT. So there is a difference there. This was not statistically significant for the RTOG grade, but was undeniably there throughout otherwise. And as I've shown you already today, that was created by an increase in urinary frequency and urgency, which peaks at about 12 to 15 months and then settles. If you look at that in a different way, so this is like a Kaplan-Meier type plot, so time to occurrence of grade 2 GU toxicity on the RTOG scale on the left and CTCAE on the right. Firstly, you can see that CTCAE appears more sensitive. It picks up more events than RTOG. And you can see that these curves separate at about 12 to 15 months and then carry on parallel. So these are events that occur and then appear to be static thereafter. So it doesn't seem that there's ongoing toxicity burden for these men, but of course we're going to need 5 years follow-up to be sure of that. Going back to the patients again, what do they say on their quality of life metrics? Well, strangely, a lot of men seem to get better after radiotherapy, despite what the urologists might think. And we can see that in the CHIP trial as well, that actually the overall quality of life detriment appears pretty minimal in terms of GU side effects. Certainly in terms of the conventional radiotherapy on the left, you can probably say visually that more patients get better than get worse. And for SBRT, it's a bit more mixed, but certainly no massive detriment in quality of life if you compare those that get better and those that get worse. The reassuring thing, however, is on the physician scales, there doesn't appear to be any significant rate of grade 3 toxicity. These were very rare events throughout PACE. There was no difference in erectile function between the two arms, so SBRT and conventional radiotherapy, with conventional in red on this scale and SBRT in green. And then the analysis that we did that did cause some questions at ESTRO was to compare between CyberKnife and conventional Linac. And this wasn't particularly because of any inherent bias in us, but PACE actually started as an SBRT, as a CyberKnife only study. It was actually funded and sponsored by Accuray right back at the start. And so we pre-specified in the protocol as we changed it that we would specifically look at the two platforms. And there does appear to be on face value a difference between those two, with conventional Linac patients seeming to experience more GI and GU toxicity on the CTCAE scale. We're we've done quite a lot of work trying to dig into this. It's not entirely clear whether it's a real effect. And of course, that's quite difficult to tell for sure because this was not randomized. And certainly in the UK, the Cyberknife centres were the high volume academic centres. And so there's maybe a lot of inherent bias in that analysis. But overall, in terms of the patient-reported quality of life metrics, when you're counselling your patients, it seems that for SBRT, you get less bowel toxicity, and you may get a bit more urinary toxicity after SBRT compared to conventional radiotherapy. So that may be important in helping to counsel patients. Excuse me, I'm going to get some water. So what about higher risk patients? PACE B obviously is a favourable risk cohort. They're going to do well regardless of what we do with them. So PACE C is basically replicating PACE B, but in upper intermediate and lower high risk patients and in the presence of ADT, which had to be 6 months in this trial. Now, like everyone else around the world, we took a hit with COVID. The recruitment had to be stopped for 3 months and then was sluggish thereafter. But I'm delighted to say that we've now caught up our recruitment projection and we're aiming to complete PACE C by June this year at the latest. So the next project is, of course, looking at nodes. So you guys have been pioneers in this area and have already published 5-fraction nodal SBRT or radiotherapy for prostate cancer. We wanted we thought that was fantastic, and so wanted to take that on into a national UK trial, and that's going to be called PACE Nodes, funded by Prostate Cancer UK now, and led by Angela Parth-Manathan, who's one of my colleagues here at the Marsden, with Emma Hall and Sunil Jain, who I think you might know, because I think he did a fellowship in Sunnybrook or Canada somewhere. So that's one thing, but the other thing that's coming through in the literature and you'll be aware of is the concept of focal boost radiotherapy. So if you look at the MRI on the left-hand side, you can see some normal looking prostate peripheral zone here on the left of the patient and a big blob of cancer on the right-hand side. And so it makes perfect sense, and patients always get this immediately. If you say, actually, we're doing a trial to look at whether we should give more dose to the area where your cancer is. And that's that we've been testing here at the Marsden in a large phase 2 study over the last decade now. And we were pleased to see this data coming out of Belgium and the Netherlands, so Linda Kirkmeyer's FLAME trial, which shows that if you do a focal boost with conventional fractionation, then you can improve biochemical disease-free survival without obvious detriment in side effects. And we published our early experience of the Delineate trial 2 years ago now, in 2022, aren't we? So this is the Delineate trial, which is sequential cohorts of patients all getting radiotherapy plus a boost in various different schedules. So cohorts A, B, and C, we're giving either 7.5 weeks or 4 weeks of radiotherapy. Cohort E, we've completed accrual on, that was giving a boost of 45 Gray in 5 fractions with this on top of the doses from PACE. And that's in follow-up, so I don't have any data to share with you yet, but hoping by next year we should have got that data to publish. But just out of interest, I'll share with you this, which I'm just writing up for publication now. So this is from the Delineate trial. And on the end of the last column here, I've used cohort B to show you that if you boost the dominant lesion as defined on multiparametric MRI up to 67 Gray in 20 fractions, that can be achieved without any obvious detriment in toxicity, either GI or GU toxicity. And the rates, as you can see, if you scan across that table, are quite similar and comparable to schedules where you don't do a boost at all. So that's quite encouraging for us. It's obviously Delineate's only phase 2, it's not randomized, but certainly encourages us to think this might be the way forward. Even more so when we look at the biochemical outcomes from these 3 cohorts. So to put it in context, cohort C were all high-risk patients, cohort B were about half high risk, and you can see incredibly low levels of 5-year progression-free survival on the right-hand side column. So less than 5% biochemical relapse for all of these patients who were quite high risk overall. And the FLAME group continue to run some excellent trials here. So they've completed FLAME. They've also completed HypoFLAME, which has looked at toxicity of focal boost radiotherapy in 5 fractions, but given weekly, a bit like you did in Patriot. And they've also now recruiting to HypoFLAME 2, which is doing the same thing, but giving 2 fractions per week. So in the last few minutes, I just wanted to talk about where the MR Linac enables us to go in prostate cancer. I can't get through an entire talk without mentioning the MR Linac in some way. So I showed you a version of this slide earlier. We're obviously on a journey from 7.5 weeks of radiotherapy down to 4 weeks and then down to 5 days, hopefully with pace. And although I genuinely haven't seen the biochemical data, I think we can all be reasonably confident that 5 fractions is going to be likely to be standard of care in the future. But the question, of course, is where do you go next? Do we stop at 5 or could we go even lower? Now, you guys, along with the Spanish teams, have been running some lovely trials looking at HDR brachytherapy as an exemplar of the ultimate in hypofractionation. What you will know from your own data, and this is Gerard Morton's study looking at 19 Gray in 1 fraction with HDR brachytherapy versus 27 Gray in 2 fractions. And you can see, I'm sure you already know, that 1 fraction is not looking good across all of the studies. There seems to be a poorer biochemical control, a higher local failure rate with single fraction radiotherapy. And we don't understand that, but it may be it's almost certainly to do with the radiobiology. And so we need to fractionate to a certain extent to overcome that effect. So this is my personal opinion, but obviously having got an MR Linac, if I wanted to test less than 5 fractions, how would I do it? Well, of course, you want optimal image guidance, and that for prostate means MRI. You want to be able to use intrafraction motion monitoring if you can't deliver your dose extremely quickly, just to make sure that the prostate's not moving or the organs at risk aren't moving, more to the point. And of course, if you have daily adaptive replanning, this gives you the opportunity to deliver a dose that's designed for that day's anatomy. It really increasingly makes no sense to do pre-planning of a prostate plan 3 weeks before they start treatment. That anatomy is never going to be the same again. Now that we've got the ability to do daily adaptive excuse me, replanning, I want to use that. So using the data from both the HDR studies, including Gerard Morton's and Drew's 2-star trial, we tried to emulate that in a planning study with Monaco system. So Monaco is not necessarily the easiest system. We normally use RayStation. So we wanted to see if we could emulate these kind of dose distributions with Monaco, ready for the MR Linac. And we found that for most of the cases, just over half, we could achieve all of the organ at risk constraints and all of the target objectives without any compromise. And for most of the rest, you could achieve something very similar to that, something close, so it would be clinically acceptable. And that encouraged us enough to start the HERMES trial. That stands for hypofractionated expedited radiotherapy for men with localized prostate cancer. And this is a phase 2 randomized trial of ultra hypofractionated stereotactic body radiotherapy in men with localized prostate cancer, funded by the JP Morton Charitable Foundation. And at the moment, this is a single center study, but we may be thinking about going multi-center in due course. And we are randomizing between 2 fraction SBRT, and the doses that we're delivering are 24 Gray in 2 fractions to the prostate PTV, which is the prostate plus 3 millimeters, and 27 Gray in 2 fractions to the GTV. And the control arm, or pseudo control arm, if you like, for us, is 36.25 to the PTV and 40 Gray to CTV, just as we would do in PACE. And so we've treated a couple of patients now. It's early days for the trial, but this is the first patient we treated. And those of you who treat prostate cancer will notice that I've cheated because I've selected a prostate with a dominant lesion anteriorly, well away from the rectum and anything else that one might be worried about. But this was the first patient. So this gentleman had, he's 73, he had intermediate risk prostate cancer. And as you can see, a small, neat bit of cancer anteriorly. So he randomized to the 2 fraction arm, excuse me, and completed his treatment probably 2 or 3 months ago now. And I rang him about every 48 hours for the first 2 weeks because I was so worried. But his treatment went very well. These fractions are long because you're giving, because we don't have tracking on the MR Linac, we did essentially 2 fractions back to back. So it took about 2 hours all told for each fraction. But he tolerated that incredibly well. The maximum he had was grade 1 GI toxicity, and that was a really soft grade 1, and had 0 GU toxicity at all at any point, and still remains completely symptom free. So obviously yet to know about his biochemical outcomes, but very encouraging so far, and fingers crossed carries on like that. So in conclusion, 5-fraction SBRT's got low toxicity and certainly similar to longer treatments, and obviously it's just much nicer for the patient. They all prefer 5-fraction SBRT. Cancer control rates are awaited from the PACE trial, but there've been favourable reports of long-term disease control after SBRT from other sources, and we remain quietly confident. 2-fraction SBRT is currently being tested in the UK, and also there's a ViewRay study in the US. In our opinion, and I know we might differ on this point, 20 fractions remains our standard of care, but watch this space, and I think I'm clinging onto that with my fingertips. I think it'll be difficult to resist the slide to 5 fractions very soon. So thank you very much for your attention. I'm very happy to take any questions.
Perfect. Thank you so much, Alison, for a great overview, especially the history going back, and I'd love to see how the HERMES trial starts out. So all in HERMES, it's the MRL only, right? You're not.
That's right. Yeah, that's right. Yeah. So I know you guys have got plans to do something on a norm at Linac, right?
We keep debating, and Janet and I are talking about this today again. So
yeah.
Anyway.
So I think for me, I have an MR Linac. I think why not use it for this, as we have one. You guys have got very accurate ways of immobilizing the prostates, which you might argue does just as good a job. But
right.
Yeah.
Do you allow space OR for the HERMES trial or no?
We don't really use it, to be quite frank. There are a few UK centres who use spacers. We're not big believers that, at the Marsden in general, but we don't use a spacer, no. And well, we'll see. But I think the data seems to indicate that the more you hyperfractionate, the more you spare the rectum anyway. And so I guess if you're going to use a spacer, probably more for fractionated than hyperfractionated, maybe.
Yeah, Sunil was a fellow with us, and actually he's the PI on the SBRT or SABR with an E study, and so we're going to participate in that. So I think that's a good way for us to learn the added value, because they're very expensive. They're
it's really expensive. And I did say to Sunil, because I've been a little bit vocal in my suspicion about the data, or at least I've not been convinced by the data out there so far for spacers, but if a trial's available, it would be great to answer the question properly. And it's also interesting because actually if it doesn't help rectal toxicity, why doesn't it help? That's the strange thing from the data that's out there. It's quite clear that it reduces rectal dosimetry and yet doesn't seem to significantly reduce toxicity, at least in the data we have so far.
Right. So a few questions in the chat box, I can just read them out. So we just answered the rectal spacer question. Marie asks, what MRI sequences do you use for your planning? Do you have a special exam card, or just your standard T1, T2?
Yeah, so we have a dedicated radiotherapy planning MR exam card, and the only ones I use are the straight T2, so normal T2 sequence, and we have a special sequence which is a gradient echo sequence that allows you to see the fiducials really nicely. For non-MRL, we use fiducials to fuse the MRI and the CT. So there are lots of different commercial versions out there. We just have our own in-house one.
Perfect. Andre Guy asks, do you have any experience with daily, or do you only give it every other day?
Yeah, no, so there used to be a split in the Marsden. We've got a cyber knife at both ends now because we're lucky. But so Nick in Chelsea used to give his SBRT daily, and I used to do mine alternate daily down here in Sutton. He's actually now, having looked at the data from PACE B, shifted to alternate day. I don't think it's a massive effect, but I think you spare a little bit of toxicity with alternate day, and most patients don't mind the inconvenience. But I wouldn't have a big drama if a patient was away from home and wanted just to get it done in 5 days. But personally, I stick to alternate day.
Yeah, so I think with Patriot, where we did weekly versus every other day, we saw acutely there was more toxicity. But I just remind everybody that was a time when we were using step and shoot IMRT and a 5mm margin. Our experience with tighter margins is that we get away with every other day, no problem. In fact, your SABR nodes, which is our Saturn protocol, we're actually treating that every other day as well, and people are just flying through treatment.
Yeah, and that's good to hear. Actually, I'll feed that back to the PACE nodes team.
Awesome. I had a question about Widmark. Why do you think even though there's the higher EQD2 in the ultra hypofractionated arm, why don't you think it was superior?
Why? So say that again. So
in the 7-fraction arm of Widmark's hypo-RT PC study, it was a similar dose to what we saw in inflame rather, and yet we didn't see superiority.
Oh, and high pro, sorry, I thought you said hypo.
High pro.
Yeah, that's right. So high pro is a conundrum, isn't it? I don't know, but you're right that it's a dose escalation study and we didn't get any improvement. And that seems to be in contrast to flame. So I don't really know the answer to that question, but it's a very good one.
The only thing I can think of, and I just haven't, I don't know Anders well enough to ask him, is what was, they intended to give 42 and 7, but what did they actually get? Like our prescriptions never meet 100%, right? So
yeah.
Were they prescribing, did they get 92% because of the, I don't know, because we have the optimal DBH criteria, and then we have the mandatory. And so how cool did they go? That's the only thing I can think of. Is it?
I think that's a good point. And you guys are always very good at writing what dose you actually delivered, not just what the constraints were. And I think none of us remember to do that as often as I don't remember to do that as often as we should, because that's important data, isn't it?
Yeah. Well, especially when you're getting down to that number of fractions. I think, a couple of gray over 5 fractions does make a big difference.
Yeah. I see a hand up, Andrew. I don't know if you can see that. It says Mark Corcombe.
Oh, Mark, go ahead.
Hey, wonderful. Thank you for that great talk, Dr. Tree. So I'm curious, on the ground in the UK, you said that 20 fractions is standard of care. Is that the truth on the ground? Are you offering prostate SBRT off of one of your many trials for those who just squeak through the inclusion criteria, or are you still doing 20 fraction, moderately hypofractionated treatment?
Yeah, so the answer includes a bit of data about COVID. So the way that the NHS is funded, they kind of sort of mandate certain fractionations. Only certain things we're allowed to do. So until COVID, SBRT was funded separately. It's got a different code, and you're not allowed to use that code outside of research. However, COVID hit and all bets were off. And so we've got a little bit more flexibility now to do what we want. And so we have, over the last 2 years, been giving a bit of SBRT off trial to the kind of PACE B cohorts, and I feel quite confident doing that. I think you have a conversation with the patient. We tend to stick rigidly, and we did for CHIP. We stuck with 7.5 weeks until the CHIP paper came out, and then everyone switched to 20. But as I said in my last slide, I think it's going to be harder and harder to cling to 20 as the data supports 5 and getting stronger. But yeah, so universally across the UK, 20 would be considered standard. A few centres will be doing a little bit of SBRT.
Wonderful. There's definitely some big geographic variation across Ontario.
Is there?
Can I ask a follow-up question as well? So are you mandating fiducial marker insertion for your SBRT? And if so, how are you doing it?
Do you mean just in the Marsden or in the trial?
Yeah. Well, in the Marsden. In the
Marsden. So at the Marsden at the moment, you either get fiducials or you get the MR Linac. So we have done some standard Linac fiducial SBRT, but at the moment it's either CyberKnife or MR Linac. So everyone gets MR or fiducial guidance. I'm a fan of fiducials, but I can't really back that up with very good data from PACE yet. I think there is a small effect on toxicity, but it's probably too small to be really meaningful or practice changing for the centres that really struggle to get fiducials in. What do you do?
So I just, I'm a bit of a transplant. So I did my residency training in London, Ontario. I did a year fellowship at Sunnybrook and drank the Kool-Aid. And now I'm currently in my first year of practice in Ottawa, Ontario. So I've moved across the province. As it is right now, we're not doing SBRT off trial. We still have the NRG GU005 open. I think there's like less than 10 patients left to accrue. It's going to be a discussion amongst all the radoncs here, what we do after that study is closed. And we all have differing opinions on the degree of equipoise. As part of my fellowship, I'm a brachy believer. So I think that I have a very different opinion on some other people here on the line. And standard of care from my point of view includes brachy. But in those who are not brachy eligible, I've been doing 60 and 20.
Yeah, fair enough.
Alison, do you what do you do for your oligo metastatic? I know we didn't talk about this, but what do you offer for like a radicals, for Stampede patient if they have oligometastatic de novo disease? What dose do you give?
This is where we get caught up in the NHS rules, because at the moment, and through the commissioning through evaluation program we ran, and all the work Nick did politically on a national stage, we can give SBRT for metachronous recurrence for up to 3 sites, but for synchronous, we are not currently funded to do that. So it makes a little bit of sense because the data is stronger for metachronous SBRT, but not a lot of sense. And that's why the Stampede trial is going to be really important for us, because it will open that up and we can treat up to 5 mets synchronously. But at the moment, it's not officially allowed, shall we say.
So the other thing that's really a head scratcher for me is the Keeshan paper that just came out with Dan Spratt in Lancet Oncology. I don't know if you saw it, looking at the MARCAP analysis.
Yeah.
So essentially, for those who haven't read it, email me if you want it. But essentially what they did is they compiled individual patient data meta-analysis of about 11,000 patients and looked at a couple of questions. One of them was duration of ADT. One was how long of neoadjuvant, if you are going to give it neoadjuvantly, is beneficial. But the take-home message was that dose of radiotherapy doesn't seem to matter in terms of hard endpoints. And really, long-term ADT seemed to be the maximal strategy for MFS and and cause-specific survival and overall survival. But I'm struggling with, well, I don't want to give 18 to 24 months of ADT to an intermediate risk patient, even if they're unfavorable intermediate. What's your sense of? I haven't digested it yet, but I just wanted to.
No. Yeah, I know, and me neither really, but I think I agree with you, and I think the decision about hormone length should be independent of how you treat the primary. I think the hormones are largely about their metastatic risk, aren't they? So for me, it's never made sense to do brachytherapy without hormones if you would normally give them hormones, and the same applies for surgery. We have this conversation with the surgeons. You'd normally give them 2 years of hormones, but instead you're going to take their prostate out. That doesn't seem to be equivalent to me. So I think we need to get away from the idea that actually the dose to the prostate determines your hormones. The other flip side is I totally back you up. I don't want to be putting my men on hormones for any longer than we need to. And if you're starting to get the kind of biochemical control rates we're seeing in FLAME and DELINEATE with dose escalation to the target, if you can get that under 5%, do they really benefit a lot from an extra 1.5 years of hormones? I'm not so sure. So I agree with you. I think 6 months hormones, unless you've definitely got high Gleason grade or high risk of metastatic relapse.
Yeah, so I think our approach will be to support GU010, which is the unfavorable intermediate. They do a decipher test. Yeah. And then if they're low decipher score, they actually give no hormones. They randomize no hormones versus 6. And if they have a high score, they get darolutamide and 6. Okay. But we're going to have to figure out how to integrate that data, because it's great data, but it kind of asks and begs more questions than it answers. Yeah, well, no, I agree. You, and then all good research should do that, right?
Yeah, no, absolutely.
I have Maria. I will send out an email about that study. Great.
It's Alison. It's Patrick from Sunnybrook. Great talk. Hi, I just had a question back to the oligometastatic question. I think you answered. I don't know if Drew was asking exactly that question of what you do for the Mets, but I think I was just for the low volume metastatic prostate cancers de novo, what do you do for your prostate as the standard of care, given the Stampede publication of a benefit of radical treatment? What fractionation do you use to deliver the radical treatment to the prostate in the setting of low volume metastatic disease?
Yeah, so we use 36 gray and 6 fractions. As you'll know from Stampede, there were 2 doses used in ARM-H Stampede. So that was either 55 and 20 or 36 and 6. And as a group, people benefited if they had low volume metastatic disease. And the comparison between the dose was pretty underpowered, and it was also uneven between low volume and high volume. So I saw on Twitter recently, there was a discussion about whether 55 and 20 achieves better control. That is not really what the data shows. So we use 36 and 6 on the basis that it's shorter, it's easier, and actually it's very well tolerated. So we do that weekly, and they very rarely run into any symptom problems at all. So that's our standard. What do you use?
Well, I was just going to ask you, would you consider, given I know maybe your NHS rules preferred it, but why don't you just give your standard 5 fraction SBRT?
Yeah, we can do. We don't do fiducials normally for the 36 and 6 because it's a bit cooler, and as I say, they get very few side effects. But I think it would be, you could assume that 36.25 and 5 would do something similar. It's a bit hotter, but at the moment we don't see the need to make it any more complicated, I guess. But I think that's not unreasonable if you have a more permissive healthcare system.
So we use 35 and 5. Yeah, sorry, go ahead.
Yeah, sorry, Drew. No, we just answer your question, Alison. We do 35 and 5, but I guess maybe because of our doing 35 and 5 in so long, we don't put fiducials in. Yeah, we use our standard margins, like 1 all around except 7 millimeters post. I think, Drew, we don't have a lot of data to say that we do that, but that's what we do.
Are you doing that weekly?
We give a choice every other day or once a week.
Yeah.
And they seem to be fine. It's more that we just didn't, we had much more comfort with a 5 fraction
sure.
than we did for 6 fractions. So we just went with what we knew. And we could have done the math on it. It's a little hotter, but my clinical experience, and others can chime in if they really fly through. It's really it's quite easy. So you don't need the fiducials, and 5 fractions either once a week or every other day is fine.
Yeah. No, I think that's right. And there's something nice for a department of having less schedules. If you can make it straightforward and everyone knows what they're doing, then there's less risk of error, isn't there?
Yeah, exactly.
Thanks, Alison. Thank you.
Thank you.
Any other questions for Dr. Tree? I want to thank everyone for tuning in, especially Alison for giving such a great talk. And since you're such an Avenger fan, and I guess you're Captain Marvel as your alter ego.
Thank you very much. I wish.
Look forward to having you, seeing you on Twitter. Everyone, if you want to follow Alison, it's at Alison_Tree. Please do follow her. It's a great conversation online, and love to have you in person.
Great. Look forward to seeing you soon, Drew. Thanks, everyone.
Have a great weekend.
Thank you. Bye-bye.